Yeah, we're going to talk about how shockwave therapy can basically help your clinic and get more referrals and help generate some new patients for you. And we'll just go over some basics of shockwave if some of you aren't fully aware of how it all works and some of the physics and some of the history of shockwave therapy. So off we go. Well, here's a little bit about me. I've written a book on back pain a few years ago. As you can see there, I'm a chiropractor. I have a special interest basically in sports rehabilitation and soft tissue treatment. I have 2 university degrees, one from the University of Windsor and the other from Macquarie Uni with a Master's of Chiropractic. I've done advanced training in soft tissue treatments, one specifically called ART. I'm one of the most experienced practitioners in Australia in this technique. I'm also a certified member of the specialist education for Swiss Dollar-Class Academy since 2016. I've presented seminars throughout Australia and Southeast Asia since 2016 for EMS. I work directly with one of Australia's top orthopedic surgeons, Dr. Munjid Al-Madiris, in his rehabilitation clinic at the Norwest Hospital in Bella Vista here in Sydney. Again, I have my book there. And I own and operate 2 clinics in Sydney, one in Mona Vale and one in Pymble. And as my book states, my ethos is treat the cause, not the symptom. So enough about me. Oh, there's my website. If you want to check out my website, I have some blogs and stuff about shockwave and a few other things on there. So check it out. Okay, so what we're going to cover today, we're going to talk about how many sessions does it take for a patient to get a positive response from shockwave. We're also going to look at what to focus on when your patient's pain symptoms don't improve. How does shockwave therapy accelerate healing? How does shockwave therapy encourage patient recall? And how does shockwave therapy provide a positive return on investment? We're going to look at a few studies for some evidence of how shockwave works and its effectiveness. And we're going to talk a little bit about a new exciting program that EMS has launched this year called GDT. And then we're going to talk about the role of shockwave and other modalities such as GDT that we introduce in GDT in clinical practice. So answering the question, how many sessions does a patient need to be treated with shockwave therapy to get a positive response? Several studies indicate that a positive symptom response can occur even after 1 treatment. So, which is pretty cool because not a lot of treatments will yield results that quick. So it's pretty cool that we have a modality that can. So some patients don't feel any different for a few sessions, up to several weeks. And we'll talk about the physiological reasons of why. But again, we have several studies that indicate it usually takes about 3 or 4 treatments, 1 week intervals with 2,000 pulses per session with an EFD, with the highest EFD. So that's the pressure, and we'll talk about the different settings on the shockwave if you're unfamiliar with that. So the EFD stands for energy flux density, which is basically the pressure. We usually talk about bars, like we say like 2 bars. But most studies, when they talk about the pressure, they talk about EFD. What to focus on when your patient's pain symptoms don't improve. So most patients only focus on their pain, which is natural. Usually that's the reason they came to see you in the first place. Unfortunately, these patients, they tend to have a very black and white view of pain. Their options are basically pain or no pain. So it's like, you either get me 100% better or you didn't fix me. So that's not the way I tend to look at it. It's a very myopic view, and it can obscure some of the benefits from the therapy. So we talk about shared shades of gray in between that no better and 100% better. Pain is a complex, individualized personal experience that is influenced by varying degrees of biological, psychological, and social factors. So I think that's important to remember when talking to patients. So they don't just blame you for not fixing them. You know, there's lots of other factors that come into it, and it might not just be the therapy. The therapy might be working, but there's other factors like social and psychological issues that can come into play and affect their physiological ability to heal. So pain defined, they just changed the definition of pain in the International Association for the Study of Pain last year. So they changed it to an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So again, here we're talking about the shades of gray between, you know, no change at all and 100% resolved. So we want to talk about the different aspects of pain. So we have pain intensity. So that's basically how much it hurts. We have pain duration. That's how long it hurts for. Pain frequency, how often it hurts. And pain character. So how would you describe the pain? Is it sharp? Is it burning? Is it dull? Is it throbbing? So when we talk about pain intensity, this is what a lot of patients tend to focus on. So it's an important variable, and because it tells you basically how much something hurts. So most clinicians either use like a visual analog scale or a simple 0 to 10 grading scale, which is what I use. So some patients, again, they overthink it when you ask them. I just tell people to think of the first number that pops in your head. Usually that's the right one. Some people tend to overthink it, but if they give you like a number, say they go, oh, it's between 6 and 7. I usually just take the average, so I'll make it like 6.5 when I write it down in my notes. But just don't let them you know, ruminate too much on it, because I think you can overthink it. And again, tell them that that their pain intensity is multifactorial. It is rarely solely due to one thing, activity, or one thing that they've done that caused it. So again, it's once they've given you that intensity, it's important to put it in context relative to their other variables, such as frequency, duration, and type. So again, I'm looking at all those things when we talk about pain, because someone's pain intensity might not change, but if they go, my frequency went from 10 times a day to twice a day, and their duration went from, it usually lasts an hour to it lasts 10 minutes, well, that's an improvement in my eyes, even though the intensity of the pain might not have changed. So here we're talking about pain duration again. That's how long something hurts for, so seconds, minutes, hours, or days. So again, we're talking an example of someone with like a tension headaches that they can last minutes to hours. By contrast, something like a migraine headache can last 4 to 72 hours. So it's substantially longer. And that's, you know, you need to make people aware of, you know, they might say, oh, it's there all day. And really, it might be only a couple hours of the day. So make sure you try and establish and get some numbers and figures so you can get a good baseline, especially the first visit, so that you can map out the changes and get some objective measures. So again, if you decrease someone's duration of pain, it usually indicates some form of improvement in the condition. However, if someone's pain duration increases, it doesn't necessarily mean that their condition is worsening. Often other variables such as sleep, stress, hydration, and even eating something that like a highly pro-inflammatory foods can affect someone's pain. So, you know, if someone had 4 hours sleep the night before and had a crappy meal at McDonald's or something, well, that's going to affect how they feel if they come into you to see you for a treatment the next day. So it might not just be that, oh, my ankle's not getting better. It might be that, well, you didn't sleep well last night and you ate crappy food, therefore your body's in a pro-inflammatory state, and that more than explains why you're not feeling so good today. So always keep that in mind. Yeah, and don't always just blame the therapy. And don't be afraid to ask probing questions. You'll be surprised what some patients will tell you they've been up to. You know, some of them, I've had stories of people like, you know, you're sitting there scratching your head and they're like, oh, I'm no better. And then they tell you they've been away on a pub crawl for the past few days. And it's like, well, okay, well, no wonder you're not feeling better. You've been drinking heaps and you're dehydrated and you're probably not sleeping much, and you're again probably eating some crappy food. So it all has to be taken in context, and just be mindful to ask those types of questions, because I've had patients where I've had been confused why they're not getting better, and then they tell me what they've been up to. Even stuff like some of my older patients, they'll be like, oh, I've been building a retaining wall for the past week, lifting really heavy stuff. And I'm like, oh, that's probably why your back's not getting better, you know? So things like that. And then they're like, oh, I didn't know I wasn't supposed to do that. So just some probing questions always help. So pain frequency, similar thing. It's an important variable because we want to measure how often something hurts. Example, someone presents with tennis elbow. They say it hurts like 6 times a day. After 4 shockwave therapy treatments, they indicate that their elbow only hurts twice a day. So that's, again, even if the pain intensity remains the same or the duration remains the same, if there's a change in the frequency, such as the example I've just shown, that's an improvement in my eyes. And I make sure the patients are aware of that, because they'll come in, they'll be like, oh, it still hasn't changed, it still hurts. And then when you ask these questions, it brings to light that they are actually improving. And I make sure that patients are aware of that so that they can see the improvement, even if they are not really necessarily feeling it. Yeah, so however, if the pain duration or if someone's pain frequency increases, it doesn't always mean that the conditioning is worsening. You know, sometimes if we have some intense treatments, that can sometimes flare things up in terms of causing some inflammation. But sometimes that's necessary to provide some healing in the area. So sometimes I'll tell patients, I go, look, you might be sore for 24, 48 hours after the treatment, but we actually want that to stimulate the healing and the repair of the tissues in the area. And if you can avoid taking anti-inflammatories, that will help that inflammatory, natural inflammatory process do its thing and help heal and repair the area. All right, so pain character. This one's a little more difficult to qualify, but here's some examples of different types of pain. We can have sharp, ache, burning. We can have dull, throbbing, radiating, shooting. If someone's pain changes in character, this can be sometimes good or bad. As I said, it's a little bit harder to quantify pain character. But usually if something goes from being a dull ache to sharp or shooting pain, usually I would assume that's not necessarily a good thing. And we can assume the opposite. So say if something goes from a sharp or shooting pain to more of a dull ache, often that indicates an improvement. But again, these are generalities. Everyone's different. So yeah, also remember the theory of pain centralization and peripheralization. So if someone comes into me and they got a bulging disc, causing some radiculopathy along their L5 nerve. And they come in one day and they say, oh, it's just hurting to my knee. And then the next day they go, oh, it's hurting down in my big toe. Well, then I know that that conditions become somewhat worse. And then the opposite, if it goes from their toe one day, the next day they go, only hurts to my knee. Well, again, that's centralization. And we assume that that's an improvement in that type of condition. All right, so Shockwave. Are we going okay, Danny? Am I going too fast?
Perfect, Adam. Yeah.
Okay. All right. So how does shockwave therapy accelerate healing? Here's some of the physiological changes that we know that occur when we administer shockwave therapy. So we get tissue repair, we get tissue regeneration, we get blockade of neurogenic inflammation, we get decreased cartilage degradation, we get decrease in the amount of substance P, which is a chemical that's released by nociceptors and C nerve fibers in the tissue. We get a local analgesic effect due to that release of some substance P. We get mechanical muscle relaxation. We get improved movement of tendon gliding due to the chemical lubricin. We get stimulation of tendon remodeling. We get stimulation of proliferation and differentiation of osteoblasts, stimulation of proliferalization of tenocytes, collagen synthesis, neovascularization, release of angiogenic growth and proliferating factors, increased local blood supply. Yeah, so quite a few things that occur, and I feel like I was doing a tongue twister with all those big words. So yeah, say all those ones 10 times fast. Yeah, that would be fun.
Don't test me, Adam.
All right. Yeah, so one thing that I like to promote to people to remember is that when using shockwave, the effects of the treatment continue to influence physiological changes long after the treatment has ceased. All right, so just like in the picture I show here, it's like fertilizer. Okay, if I put fertilizer on a plant such as this, it's not going to just have effects on that plant on the day I administer the fertilizer. It's going to have effects days, weeks, and months later. So shockwave is a similar thing. And so that's why I tell my patients, even just having one treatment can have beneficial effects months later that we've actually measured in case studies. All right, how does shockwave therapy encourage patient recall? So some of the advantages of shockwave: it's safe, it's effective, it's reproducible, it's versatile, it's cost effective, the effects are long lasting, and it generates referrals. So talking about how it's safe, here's some studies that show its safety. One by Schmitz, 2015, concluded shockwave is an effective, safe, and non-invasive treatment option for tendon and other pathologies of the musculoskeletal system. Another study I love to quote is a meta-analysis, which we know is the absolute pinnacle of the evidence hierarchy, by Liao in 2018. It was included 19 RCTs with almost 1,200 patients, and it concluded of the 562 patients who received shockwave, 627 received a placebo or other comparative treatment. Of those 562 patients, there was 0 adverse events, side effects, or complications in the treatment arm, which is, to me, that's about as safe as it gets. You can't get better than 0 adverse side effects or complications. So that's as good as it gets. Shockwave is effective. So again, the same two studies that we just looked at by Schmitz and Liao. The efficacy of Shockwave is clearly supported by the cumulative data. 88.5, 23 out of 26 of the RCTs in the systematic review on. So the R is on RESWT, just means radial. And 81.5 of 66 out of 81 RCTs on focus. So that's what the F is for in that. And on Pedro had a positive outcome. Significantly better statistically than other placebo or alternative treatment modalities. And again, the meta-analysis by Liao is Shockwave therapy exerts an overall effect on the treatment success rate, pain reduction, and range of motion restoration in patients with knee soft tissue disorders. So that meta-analysis was looking at knees specifically. So Shockwave is versatile. There's loads of indications that we can treat with Shockwave. Here's just a few of them. I'll go through another list here as well. So here's a list. So we got myofascial pain syndrome. So trigger points, it's super effective. If you've never used it for trigger points before, it's I used to do some manual trigger point release. I like never do that anymore just because I just pull out the Shockwave and I get a way better result, and it saves my hands as well. Tension type headaches, osteoarthritis, in pretty much any joint. Spasticity, they've done some studies with kids in China, which was I haven't got the results for that, but I heard from Dr. Schmitz that they were getting some pretty cool results. Idiopathic low back pain, idiopathic cervical pain, obviously all the tendinopathies. We got Osgood-Schlatter's, acute and chronic soft tissue wounds, primary and secondary lymphedema, and non-fracture unions. So that's another cool one that people aren't aware of, and that we try to promote to like orthopedic surgeons and such, is that it helps like hips that won't heal after fracture by stimulating some of those physiological effects that we're talking about, like the osteoblast and the tissue and cartilage regeneration in the area. All right, I just need a drink. So we have here. So Shockwave is cost effective as well. Usually treatments that are required for most musculoskeletal conditions are about 4 to 10 treatments with about 1 week intervals. Cost varies depending on the practitioner in the clinic, but usually $80 to $150 per session. And again, that's about once a week. Patients can get health fund rebates. The amounts vary depending on which health fund they're with, so that helps with the cost. So the minimum cost for if they had 4 treatments at $80 a visit would be about $320 up to about $800. Okay. So people can administer it. We have chiropractors, physios, osteopath, exercise physiologists, radiologists, orthopedic surgeon, podiatrists, and sports med. Pro is one treatment can provide pain healing effects up to 3 months later, as I mentioned. It's very safe, no adverse events. Post-treatment, relatively inexpensive treatment option, and many allied health practitioners can use it. Con is it's a mildly to moderately painful procedure. Obviously, you can set the pressure, so you can kind of control basically how much it hurts. You also need to use contact gel. It can be a little messy, and the patient needs to find a practitioner that has a Shockwave machine, obviously. Cost effectiveness compared to cortisone. So cortisone, treatment requires about 1 to 3 injections per year. They usually give them at about 2-month intervals. So the cost per injection is about $250 to $300. That's usually ultrasound guided. And patients can get a Medicare rebate here in Australia if they're referred by a GP. So it'll cost them out of pocket approximately $130 per injection. So if they get all 3 injections, it'll cost them $250. Sorry, if they get 1 injection, it's $250, and if they get 3 injections, it's $750. And then if they get the rebate, that's obviously drops out a bit. So people can administer it, usually radiologists, orthopedic surgeon, podiatrists, obviously foot only, and sports med. So the pro is that you get fast pain relief 2 to 7 days after the injection. Usually you're getting the benefit of the cortisone. It usually lasts 1 to 3 months, and it's relatively low cost. The con is it has poor long-term relief. There's obviously a risk of infection because it's an invasive procedure, and only certain practitioners can use it. There's also risk of tendon rupture, which is approximately 2.4 to 10% of patients with, for example, with plantar fascia injection, with greater risk associated with higher number of injections. So if they get more injections, then those numbers increase, obviously, for the plantar fascia rupture. But you get similar effects in other areas if you're doing like the shoulder with supraspinatus and the elbow if you're doing like a tennis elbow. So cost effectiveness for PRP compared platelet-rich plasma. So treatments requires most clinics require 3 injections with 1-month interval. So the cost, you're looking about $300 to $800 per injection. So the minimum cost is going to cost you at least $900 for the 3 injections. Again, the people who can administer it are usually radiologists, orthopedic surgeons, podiatrists, and sports med. The pro is it has good long-term effect, good long-term relief, and has low risk of adverse events. Con is only certain practitioners can use it, and obviously there's a risk of infection, and it doesn't have the best short-term benefits. So the first 1 to 3 months, they don't tend to get much like a huge benefit like they would say with cortisone. All right, so here's one of the devices that EMS sells, the Shockwave devices. It's the Smart 20, I believe. So how does Shockwave therapy provide a positive return on investment? The new dollar class radial Shockwave retails for about $27,000 plus GST. The one here in the picture, the Smart 20, retails for about $22,000 plus GST. So how it helps you with return on investment, it helps generate new patients, adds another treatment modality to your clinic, saves practitioners' hands from doing loads of manual work, so it can extend your working career, allows practitioners who may struggle physically to continue to perform manual therapy. I know some older practitioners that using tools such as these has extended their career. Again, it's safe and effective, so no major risk of adverse events using it. And the device is not overly complex to use. It's easy to start. Patients, you can start straight away without extensive amounts of training. And there's also low maintenance cost. You have to get the handle refurbished approximately once a year. It's about $1,400 US. And it depends on how much you use it, though. If you use it more, you might have to get it done more than once a year. Obviously, if you use it less, then it might be less. Okay, so if we can first improve patient outcomes, so this is kind of what we look at. Provide an immediate reduction in pain while starting a long-term physiological healing response, increase range of motion and ability to load, allow for better uptake of prescribed rehab exercises, including ability to do more appropriate exercises, and if we can also speed up recovery, then the following will occur. You'll get increased patient retention, you can get increased referrals, treat more patients in a day, and again, save your hands and generate that positive return on investment. So talking about referrals, this is one of my examples that I talk about in my clinic to some of my patients with plantar fasciopathy. So I've obviously changed the name for anonymity. We'll call her Mrs. Plum. She was a 65-year-old female interior designer presented to the clinic. She'd had a 2-year history of right plantar fasciopathy. Her heel pain was about 6 to 8 out of 10 throughout the day, and it was made much worse by prolonged standing or walking. So she had been to see over 6 physiotherapists and podiatrists. She'd been seen 3 sports med and 2 orthopedic surgeons, and she'd told me that she'd spent over $10,000 in those 2 years seeing all these practitioners. And obviously, if she's still a 6 or 8 out of 10 on the VAS, they hadn't changed her symptoms a whole lot. She was very frustrated because she was unable to see her daughter who lived in Hong Kong, or her granddaughter, because she wasn't able to walk without significant pain. So she couldn't really get there. So she hadn't been to see her daughter for over 2 years. So that she was really kind of emotional and frustrated about that. She was extremely dubious about my ability to help her, because obviously you can see she'd been 6 physios, 3 sports med, and 2 orthopedic surgeons. So you got 11 different practitioners all telling you they're going to fix you. So I was a 12th practitioner telling her I could help her. And so she just thought I was basically full of it like the rest of them. 8 weeks after she first saw me, she was on a plane to Hong Kong visiting her daughter. We'd managed to resolve her plantar fasciopathy significantly. It was about 80 to 90% better after 8 weeks of treatment. So since I got her symptoms better and she was able to go visit her daughter, she used to rave to all her friends about me. She sent me over 9 patients over the years. This is probably about 4 or 5 years ago. I first saw this patient, and again, a lot of those patients were similar kind of cases, like tendinopathies and stuff. So, of those patients, most of them were long-term patients requiring, anywhere from 1 to 6 months of treatment. And some of them I still see as regular patients. So it's helped generate a lot of income for my clinics. Yeah, she was completely symptom-free for about 4 years before she came back to see me with a small flare-up of her plantar fascia. But we were able to resolve that in about 3 sessions. All right, what is a shockwave? So just got some examples of natural shock waves. So like the lightning, the thunder creates some shock waves. Here we have an airplane breaking the sound barrier, creating some shock waves, and the other one we have a bullet creating some shock waves there. So in physics, a shock wave is a type of propagating wave that moves faster than local speed of sound in the medium. So again, we have those examples in the pictures. A shock wave is characterized by an abrupt change in pressure, temperature, and density of the medium, and by the energy it carries through, which dissipates relatively quickly with distance. So it's a natural phenomenon to a therapy. This is our new Dola class that we've just come out with this year. We'll talk a little bit more about it. So shockwave therapy, it's been used to treat musculoskeletal disorders for over 30 years now. So again, shockwave is a single acoustic pressure pulse. It is characterized by a rapid rise and to a peak pressure and then a drop below ambient pressure, which creates these shock waves. The energy promotes repair, regenerative processes of the bone, tendons, muscles, and other soft tissues. All those indications that I put up earlier. So again, here's the console. We have the pressure settings in bar. We have the frequency in hertz. We have the different analgesic modes. We have a ramp up mode. We also have the impulses. That's how many hits. Basically, the projectile hits the applicator, and we have several different protocols, and we have another mode called burst mode on there. So as we can see here, a little bit of the physics of how it works. There's a projectile inside the handle that gets pushed through with compressed air at speeds up to 90 kilometers per hour, which generates kinetic energy, which is then converted and delivered to the target tissue through the skin. So it hits the applicator, and then that generates the shock waves, and through that we generate what are called cavitation bubbles, and they're caused by the second phase of after the compression phase, the tensile phase, which is the drop in pressure that causes these cavitation bubbles. And again, we use a contact gel, because if you don't have that, you lose all the energy. Here's a little example of what shock waves look like from the applicator tip. Hopefully this works. So you can see the little black bubbles. Those are the cavitation bubbles. So those are what we tell people is why we get the physiological changes in the tissues. It's due to those cavitation bubbles. I'll just run that one more time. Cool. And here's me treating an Achilles tendon with some shockwave. This is a technique I call ironing. It's basically where you're moving the shockwave up and down the tissue to help break down some of the adhesions and scar tissue in the tissue you're treating. Hopefully this works. Oh, go back. There it is. So I'm basically going up and down the medial aspect of the Achilles tendon there. All right, so we'll go through a little bit of the clinical evidence. So this is that study again by Schmitz that I mentioned earlier. The purpose was to perform an evidence-based systematic review of literature to examine the efficacy and safety of shockwave therapy for musculoskeletal conditions. Again, their conclusion was that it's an effective, safe, and non-invasive treatment option for tendon and other pathologies of the musculoskeletal system. Again, we talked about the 88.5% of RCTs with radial shockwave and 81.5% of the RCTs with focused shockwave in Pedro had a positive outcome. So that's like, those numbers are awesome. You don't see those kind of numbers for very many other treatment modalities. Like the 88.5, that's almost 90%. It's crazy numbers. Focused shockwaves do not provide better results than radial shockwave. As you can see here, they're pretty close, but in effect, radial had somewhat better effect than the focus there. They also concluded that applying sufficient energy to the tissue can affect the treatment results. So if you don't give enough, pressure to the area to generate enough tissue adaptation, you're just not going to get the results. So that's why I try and tell patients, we got to try and turn up the pressure to what the max you can handle in an effort to get the best physiological changes possible for your tissue, obviously within tissue tolerance. So the two studies demonstrated that the application of local anesthesia in the area treatment adversely affects the outcome. So we don't want to use any type of local anesthetic on a treatment area before. Like, some people think, oh, if I use some like lidocaine on the area to numb it a little bit, then we can really pump the energy up, and that will help generate a better result. But we want the patient to be able to feel some of it, so that they can give you some feedback, because you can actually cause some tissue damage if you go too hard. So if you get a local anesthetic in the area, you're not going to feel anything, and you're not going to be able to provide that feedback. The optimum treatment protocols, about 3 treatments and about 2,000 impulses per session. So this is the Liao study from 2018 that I mentioned before. The aim of the study was to determine the clinical efficacy of shockwave for knee soft tissue disorders compared to the efficacy of different shockwave types, energy levels, and intervention durations. Their conclusion was, out of 19 RCTs, 1,189 patients, again, there was no adverse events, no side effects or complications were reported, which again says a lot about the treatment, that out of almost 1,200 patients, they had no problems whatsoever. Their other conclusion was the study provided limited to moderate evidence that both focus and radial shockwave with long intervention periods are superior to those with short intervention periods. Meaning, like, if you treated someone only for like, say, a couple weeks versus like a month or two, you got better effects with the month or two treatment. All right, so we have this study was radial shockwave therapy is safe and effective in the treatment of chronic recalcitrant plantar fasciitis, results of a confirming randomized placebo-controlled multi-center study. So the purpose was to demonstrate whether there was a difference in the effectiveness between radial shockwave and placebo in the treatment of chronic plantar fasciitis in a randomized controlled trial. So the study was 3 sessions with an interval of 2 weeks in between, and the radial shockwave protocol was with the 15 millimeter applicator, 2,000 impulses, and the EFD was 0.16 millijoules per. So that's the pressure at 8 hertz and 4 bars. This was a follow-up. After 3 months, you can see with the blue is the radial shockwave effect, And you can see a significant decrease in the VAS score compared to the sham, and even more so after the M12 is the 12-month follow-up. So Swiss dollar class is proven to be efficiently treat plantar fasciitis and significantly relieve pain on short term with a 72% decrease on a long-term basis. An important placebo effect has been observed, however, with Swiss dollar class treatment is better than placebo in this study. All right, now this study done by Romp was looking at eccentric loading versus eccentric loading plus shockwave for Achilles tendinopathy mid portion. Purpose of the study was a previous RCT had shown comparable effectiveness of standardized eccentric loading training and radial shockwave in patients suffering from chronic mid-portion Achilles tendinopathy. The purpose is to test whether a combined approach might lead to even better results. And funnily enough, they did. Combination of shockwave treatment and eccentric loading has significant better clinical outcomes than eccentric loading alone. So combined treatments leading to a significant reduction in pain. So we're going to talk a little bit about this when I introduce GDT later. This is part of what we talk about with the rehabilitation being part of the GDT model, based on studies like that we've seen. And again, there's some of the changes. This study was another Romp study. Radial shockwave treatment alone is less efficient than radial shockwave treatment combined with tissue-specific plantar fascia stretching in patients with chronic plantar heel pain. So they had 152 patients divided into two groups. So receiving either 3 sessions of radial shockwave or radial shockwave combined with 8-week plantar fascia specific stretching program. And patients' pain was evaluated at baseline 2, 4, and 24 months. Conclusion, the combination of shockwave treatment and stretching exercise has significantly better clinical outcomes than stretching alone. The combination of Swiss dollar class treatment and stretching exercises not only provides short-term pain relief, but long-term treatment success. So again, here's some of the numbers. So as we can see, just going back to that, again, we're seeing time and time again, when we combined the shockwave with some of these other standard treatments, you get even better results. So that's why, again, we're going to talk about with the GDT that we're trying to incorporate the rehab component and make that part of standard treatment for everyone so that you can get these better results for your patients. So extracorporeal shockwave therapy versus local corticosteroid injection in the treatment of chronic plantar fasciitis, single-blinded randomized controlled trial. So this study, they had 40 patients divided into 2 groups. Group 1 had 5 sessions of shockwave. Group 2 had a single cortisone injection. They looked at pain in the morning and during the day based on VAS and functional abilities using the foot function index, and satisfaction were evaluated before treatment and at 4 and 8 weeks. So their conclusion, both interventions caused improvement in pain and functional ability 2 months after the treatment, but Swiss dollar class shockwave treatment has a better antalgic effect than local corticosteroids injection. Patients were more satisfied with radial shockwave treatment, and therefore Swiss dollar class treatment seems to be a safe and alternative for the management of chronic plantar fasciitis. So again, they didn't talk about what we mentioned before about the cons of the cortisone injection. One, it hurts like hell. A lot of people aren't told that, and like it's really excruciating. I've had a few patients get it done, and they said it was really excruciating. And also, you have the adverse effect of 2.4 to 10% chance of rupture of the plantar fascia. So it's not too cool when people go get a treatment, and then after that treatment they go for a run or something and they totally rupture their plantar fascia, and then they have to have surgery to remedy it. So that that's, I don't think too many people are looking to kind of get that kind of result from a cortisone injection. So radial shockwave treatment is preferable to corticosteroid injection. Requires a period of rest after the administration. So that again, the cortisone requires some rest, while the radial shockwave, you can walk after treatment. You don't have to take the day off or anything like that. It's important to note that corticosteroid injection and mainly multiple injections may also cause complications. So that's what I was talking about before. And there's the VAS and the changes. We also look at osteoarthritis. So again, shockwave is effective for treating osteoarthritis. So this study had 70 patients divided into 2 groups. One receiving radial shockwave and the other having placebo. And the conclusion was that the shockwave with the power handpiece, which is a slightly more powerful handpiece that we use, is effective in reducing pain and improving knee function at least during 3 months after the beginning of the treatment. And there's the changes at 1 week, 4 weeks, and 12 weeks. All right, so we made it to the GDT. How are we going for time here, Danny?
2 minutes, but don't worry.
Okay.
We've got some questions as well, so okay. You're going well.
Okay. All right. I'm trying to do it before my voice fails here. All right, we'll just go over this real quick. So we have 6 steps with this new protocol that we've come out with. So the first is to assess and engage. So we want to figure out what's going on with the patient, get a proper diagnosis. So the second one is the use of our high-powered laser for treatment. The third is the shockwave, radial shockwave. Fourth is focused shockwave. Obviously, you don't necessarily need both. You can have one or the other. The fifth step is rehabilitation, and the sixth is follow-up. So doing some testing post treatment. So again, we have 6 steps, 1 goal: pain-free patients. So again, with the 6 steps, so we want to assess your patient's pathology with key questions and tests, engage your patient with a treatment plan and outcome. The second being our high-powered laser. Treat with high-powered laser to reduce inflammation and pain. So what we're promoting, again, with our laser is the combination of using high-powered laser with the radial shockwave. So some patients, when they're really acute, or if they're in significant levels of pain, may not be able to tolerate even the lowest setting on the shockwave device. So that's why we've come up with the high-powered laser, because the laser, you basically don't feel anything except for a bit of heat in the area. It's a non-painful treatment, and what it'll do is it'll give you some pain relief, a little bit of analgesia, which will then allow us to start to use the shockwave on an area that we previously couldn't. So that's the big combination that we're trying to promote with these two. Is the laser will allow you to treat some acute things that you may not have been able to treat with the shockwave alone, because it would have been too painful for the patient. And then rehabilitate, step 5, we want to perform complementary set of exercises. I've been doing that for years. I always use exercise and rehabilitation with all my patients to help get a better result. And then step 6, we want to evaluate, basically follow up and see how the patient's going, do some objective measures, and look at where they were at baseline compared to how they are after several visits. So we found that GDT, we can safely treat 90% of all musculoskeletal disorders, which is pretty cool. Treating patients has never been easier. Using this protocol, GDT devices, whose unrivaled performance enable best clinical outcomes, while their design simplifies practice workflow. We believe it's a game changer. All right, what are we on to here now? Role in contemporary clinic practice. So basically, my view is that the landscape of allied health is migrating to a new paradigm. Doctors and insurers are demanding more validated, safe, and effective forms of treatment for patients. And as an allied health practitioner, it's imperative that we stay current with the new and emerging treatment modalities such as shockwave and laser therapy, or we risk falling out of favor with the healthcare systems, private health funds, and insurance companies. Of even greater concern is the real risk of becoming antiquated in the health profession, which I don't think any of us want to do. In order to stay relevant and provide patients with the best possible therapies available, we must learn and adopt some of these new therapies. And we all know that you got to stay current. If you're not up with the new treatments, you will become antiquated, and you will risk losing patients and not being nearly as effective as the other practitioners. It's my strong belief that in the future, insurers and private health funds will only start to pay practitioners who can objectively show improvements or benefits in their patients. So I think the day of practitioners just saying, "Oh yeah, I'm fixing everybody," and not have any objective measures to show that, they're numbered. They really are. So using devices like we're suggesting here are going to help you stay current, and you won't have any problems if you can show some of these objective measures, which is also what we're talking about with GDT. All right, so we have some education that you can get online through Swiss Dollar Class Academy. Here's the website. I made it, did it.